Right, let's go ahead and get started. I know it's a little bit past the noon hour. I'm sure some folks will join as they can. So welcome, everyone. I'm Nicole Fisher from HealthInfoNet, and you are joining our closing webinar for our Social Health Data Action Plan convening series. The information that we're going to be presenting on today is to sort of do a high-level overview of what we took away from our individual deep dive sessions that we did during these convenings, wrap it up nicely for everybody, and then also finish up with some next steps. So I will start and highlight and do just a little bit of background. Looking at the purpose of HealthInfoNet, as we are the state's Health Information Exchange, or HIE. With our mission here at HealthInfoNet is to support our healthcare community and create lasting improvements and in the value and quality of patient care and population health. We provide a suite of health information services to our participants, from data integration through data transmission services. Another brief look at some of our data connections, and certainly also we may not spend a lot of time on these intro slides, but if folks have questions or they're interested about something that they're seeing here presented today, you're always more than welcome to reach out to us, and we really enjoy having those conversations and answering any questions that folks have. So as we think about the work and what really started this initiative and really thinking about social health data, it's really important, I think, to look at it from a broad perspective. So this was certainly a slide that folks saw in our introduction webinar that I think is just really important to start off even this closing with, and thinking about how originally, I think, folks really looked at the medical factors that were impacting folks. And now we've grown and we've evolved, and there are so many other factors and important considerations to think about when looking at health outcomes for individuals, and looking at other areas such as socioeconomic factors, environment, health factors, and access to care. And then ultimately, obviously, there is some impact in cost and what that looks like in those projections that we're showing here in this slide. Working within our purpose. So obviously, as I mentioned, what we strive to do here at HealthInfoNet, we obviously want to help improve health equity within our current parameters as a health information exchange. And just some important things to highlight around our participants and the connections that we have, that the Health Information Exchange's participant agreement allows the connection with HIPAA covered entities, and that improving health equity is a measure of our mission. It is important to us. It is why we wanted to do this convening and gather folks from around the state, because we know how important it is. And when you think about starting with that collecting of data in a clinical setting, we can also work really closely with our community-based providers as well to help determine the best and most appropriate use cases for the data in order to affect change for our population here in Maine. So a convening overview really about what was this convening series about? It was capturing the ways in which our healthcare providers across the state are collecting, storing, and using social health and sexual orientation and gender identity information, and allowing stakeholders from Maine's health systems, the federally qualified healthcare centers, to really share in their knowledge, their best practices, lessons learned, emerging strategies, with their peers, and also to just be able to talk to each other, see what everyone is doing, be able to present on those things, be able to ask questions of those folks, while also being able to have varying participants listen in on this conversation and on this dialogue that we had with folks. So we did have these two key focus areas in looking at social health, which really is the upstream of social, economic, political circumstances that are impacting the downstream health risks, conditions, outcomes of persons, communities, and societies. And also looking at sexual orientation and gender identity. So the ways in which individuals identify themselves, whether biologically, emotionally, romantically, sexually, or any of those identities that are related also to their health status. We had some really great stakeholders that presented in our introduction in our initial webinar that we did that we still want to highlight. We find them to be very important partners in this work. So having folks from the Maine Council on Aging, Maine Primary Care Association, Maine Hospital Association, Maine Medical Association, and Center for Quality Improvement, as well as Civitas Networks for Health joined us and spoke to that. So certainly, as you know, if you've joined in on some of these webinars, you know that they have been recorded. So certainly folks will be able to go back and listen to those presenters and them talk about what this work means to their organizations. And then we also want to highlight and appreciate our deep dive presenters, those folks from Northern Light Health, from Maine General Health, from Maine Health, from Nassau Healthcare, and YCCAC, PCHC, and Greater Portland Health. They were amazing presenters and really shared amazing information, I think, and are really going to help continue this conversation and move it forward. So we are very appreciative of them and their time to participate in these convenings with us. So let's talk about the convening results. So as I said, the deep dives were broken up into 3 different sections. We had data collection, we had data storage, and then data use case and action. So we're going to get into each of these areas and talk about some of the findings and the information that came out of those talks. So data collection, one of the biggest things that we spoke about during this deep dive were what social health risk assessments our providers were using. So being able to look at it, whether it was using a prepare tool, whether it was using other CMS tools or assessments. Those were certainly some of the bigger ones or largely what folks were using. But then there were also some other examples that came out of our discussions, which included the hunger vital signs. Some folks were utilizing alcohol, drug, and tobacco screenings that they were doing, as well as Maine Health focusing in on the diaper insecurity screenings as well, and felt that these were also really important areas and things to highlight. As we think about what some of the providers are prioritizing, you'll see some of the priorities that are bolded, but obviously all of the areas are important here that are listed in this slide when you're thinking about really basic demographic and personal characteristics that folks are getting out of these assessments, employment status, food insecurity, that's obviously bolded. I think that was something that that really came out of our discussions, was understanding that food insecurity is a very high priority for folks throughout the state, and understanding who of their patient population is at risk for food insecurity. We obviously talked about housing stability and quality, and being able to assess for that for folks, incarceration history. What are some folks' childcare needs, utility needs such as heating and so on, electricity. Safety and domestic violence is also important, but also social integration and support. I think that also is certainly something coming out of the pandemic that's becoming more of a priority for folks, being able to assess what are some of their social needs and possibly any social programs that could be of use and help to patient populations. Data collection. So how and when are these assessments used by providers? I certainly, I think a lot of the focus and priority for folks as we talked about this was really utilizing primary care practices as, the initial and the go-to, as well as, some behavioral health settings, certainly. And I think that will continue to grow as maybe some other non-traditional areas in order to collect this data. But certainly the main and primary focus appeared to be primary care practices. Was really the initial. Most of this is happening, once a year. It's at annual visits, but obviously, more frequently as needed, assessments done at varying times, not just that annual visit, but if it came up during conversation at another type of visit, and it appeared to be something applicable to that situation, if I could speak. And then also understanding that this is something that's happening for all patients. So there was definitely some really great conversation that happened around those individuals, those adolescents and children, folks under 18, and who was providing that information, whether it was engaging a parent or guardian, or if folks were, if individuals are older than 13, being able to allow that individual to be able to answer some of these questions, and doing it in a way that also protected their privacy. So that was another really great theme that came out of our conversations, was the idea of confidentiality, being able to protect some of this information, being able to flag it as sensitive information. But really sort of understanding and capturing, who is, getting these assessments, who's being asked to do these assessments by their healthcare providers. Data collection. So this was also really interesting, very eye-opening, very enlightening. How are patients able to complete these social health risk screenings? One of the highlights and takeaways, I think, even for us here at HealthInfoNet and probably for other folks that were listening in on the webinars, was the high usage of being able to use online patient portals now. So if folks are going in prior to their visits, maybe they're doing an online pre-registration, being able to complete these assessments, questionnaires in the privacy of their own home, and being able to do that in a way that made them feel comfortable and safe sharing this information. Understanding that PCHC is using self-service kiosks during registration. So having that ability, in their waiting rooms for folks to be able to also gather that information and get it if they weren't able to do it ahead of time. Printing forms during intake and allowing individuals to have that information, on paper as they're in the process of being roomed for their visits and their appointments. Being able to do it right there, have that information, be able to be given to staff members to be inputted into systems, but also to be able to have a dialogue with nurses, with care managers, case managers, or community health workers. I think that was another really great takeaways, the use of community health workers and how that this can be done too, and even sort of that non-traditional office setting. So if folks are going into the community, being able to utilize that role as well to gather the information. So what happens with patients' social health risk inputs? So as I mentioned, in that previous slide, those are just some of the ways that information is provided. So whether the screeners were done via paper, or done, with a provider, with a nurse, with an MA, with a case manager, having those folks be able to transcribe the screening responses into the EHR, having providers be able to review those screeners. So also too, whether it was information that was put into an online portal, there always was a process where that information is inputted into their record. It's able to be reviewed and signed off by a provider that's working with that individual in order to validate any clinical diagnosis that needs to be attached to a visit, or if there needs to be further discussion with patients, then that in turn helps to guide future interventions. So whether referrals need to be made within an organization itself, or if, that information gets sent to a case manager or a social worker within that organization, and then ultimately a referral needs to be made to an outside community-based organization, all of those team members are working together, and there's a process in place in order to make the necessary next steps, interventions, and referrals, with the goal that providers work with patients to establish the goals and mitigate some of those social risk factors over time. So it's a really great way to see, the process from start to finish, and really understand that not everybody does it the same way. I think there's obviously some really common themes overall, but the workflow might be different and might need to be different based upon the area to which you live in, the organization that you are working at, but that ultimately these sort of 4 high-level key areas are being met. What challenges are being faced when attempting to collect this information? So that was another key area of discussion that we talked about during these convenings, and in particular the data collection convening, which is looking at assessment availability, and particularly when you're talking about folks who English is not their first language, not their primary language. What are some other cultural needs that need to be thought about, whether it's translating forms, whether it's having somebody be able to translate during a visit with an individual to make sure that folks are understanding, what is being asked of them, the questions in those assessments and questionnaires. So also looking at varying health literacy levels. So having folks be able to understand, like I said, what's being asked of them. Response inconsistencies. So identifying inconsistencies and risk between the survey responses and then, what's happening from a provider-patient conversation. Duplicate assessments. So that was also something that we really talked about. It was kind of a common theme, interestingly enough, throughout the convening series, as to how this information can be shared in order to prevent duplicate assessments from happening, from creating that fatigue of individuals who, may be going to multiple providers or may have, multiple office visits, and making sure that they're not having to retell this information every time. Or that if necessary follow-up happens, there's additional, there's a foundation of information that's been given, so that it's just not a traumatizing experience, just having to answer some of these questions that can be really sensitive and delicate in nature, and that you're really respecting that individual and their needs, given a time where they might find themselves to be very vulnerable and in needing some other social supports. Data collection automation. So technically being able to automate the data collection within electronic health systems versus paper-based mechanisms. So finding a way in a common ground where there's not a lot of extra time, effort, and energy that's going into, having to use a paper-based workflow, but also being able to trust and rely on those technical solutions being there when you need them, and having it be a very automated process. So what can organizations' tools do for them in regards to when there are positive screeners and there is a diagnosis that needs to be included into an encounter or office visit? What does that look like? So that was definitely also something that we spoke about. How these challenges are being mitigated. So what were some of sort of the success stories or the ways that folks were finding, to get through some of those challenges, being able to use the community health workers to serve as the care navigators. So that was a really big common theme, was to focus in on a particular staff role that could help answer questions, make sure that folks understood, be able to gather more data, or do it in a more efficient way, using some training and deploying the right staff member to understand how to have sensitive conversations. Another theme I think you will see throughout this is also the idea of educating folks on, and whether that is staff, whether it's providers, on how to have some of these conversations, and making sure that they have the tools necessary to be able to do that, and really the importance of that training and education. Normalizing health risk questions, the need for form healthiness, like medical treatment plans. I think that's the other thing, is that this is still new, I think, to a lot of folks. And as we all know, as we've all at some point received healthcare, and you go to appointments and you get asked a lot of questions, really understanding and normalizing, why are we now being asked these questions? Why is this information important to know and to have? Is huge, and I think really can help with the response inconsistencies. Duplicate assessments, so talking about how to share this information across patient care teams. Another key theme that we talked about was really, from an organizational perspective, who has access to this information, who needs to know this information, making sure that there are things that are able to be shared, as I mentioned, so that folks aren't having to always repeat themselves, so that folks know, yes, they've already been asked this. Or if a referral needs to be made, an individual isn't starting from scratch as far as gathering the data. It might just be that they will confirm, yep, this is what's going on, and this is what's necessary and needed for next steps in making this referral, but taking that need to have an individual go through a story again to repeat their history. And then the data collection automation, being able to continue to challenge sort of the status quo, urge new solutions to combat social needs. So being able to find some of those technical solutions and really help to streamline a process for gathering this data that makes sense, and that not only are you gathering these questions and getting this information, you're able to get it in the hands of folks that need to have this, but to also have it in a way that folks within their own systems can also, track trends over time, see any changes to get sort of a bigger picture, have that longitudinal record over time, and to use the technology in a way that's going to be helpful, not only for providers and the staff, but in patient care in general. Data storage. So this was the second deep dive and talking about, okay, we've talked about how it's collected, who's collecting this information. Now, how is it being stored within folks' electronic health records. So what was clear was obviously every one of our presenters, they use a different EHR system. So they are listed here. And for those folks who do this work, I'm sure that these are all very familiar organizations and companies that folks are aware of. So how are these data elements stored in technical systems? We talked about those screeners. So we've talked about how that information is gathered. So whether it's done via an individual, sort of a self-serve, a patient doing it themselves, either through one of the kiosks, whether it's an online portal, whether it's information that is gathered from a provider during a visit or something that's transcribed. Ultimately, what everybody said is that data is stored discreetly and also in varying document forms. So it's kept in the form of local coding, and sometimes it can be transformed into standard coding. Then when you're looking at the diagnosis, that is also just stored discreetly in forms of documents. It's included in active problem lists, office visit notes, and counter records. And this can often be transformed into standard coding. So once that information is given, once a diagnosis is given, that seems to be something that's much more transferable or transformable with the coding aspect. Interventions stored discreetly, also in forms, kept in the form of local coding, sometimes can be transferred. So that was also sort of the same with screener information, that depending upon what interventions made the most sense based upon how an individual answered those questions, depending upon what was the associated, diagnosis, that there were varying levels of ways folks incorporated that into their record, and not always was that something that could be transformed into sort of a standard coding set. Similar to goals. So same thing with interventions, stored discreetly, also can be in some note form, and that also sometimes can be transformed into standard coding as well. But all to say that the information lived within the record. It was just if that was more of a document form versus that standard coding process in their systems. How are social health data elements stored in technical systems? So this was a really great quote from the convening that we wanted to include here in this slide from one of our presenters, that although codifying diagnoses and moving toward intervention is the objective, the whole system needs to be documented to improve a patient's well-being. So I think it's really easy to sort of think about, yes, we have these steps, we have these processes. It's really important to have a diagnosis, an attached based upon that questionnaire and screener. It's really important that we move towards having interventions for individuals, but that there is also that bigger picture. It's that whole system that needs to be looked at that is going to improve a patient's care and individual's care long term, and is really crucial to their well-being. Data storage. So what are some technical safeguards in place for protecting patients' social health information? So as I mentioned before, we talked about, which is highlighted here in the second bullet here, patient portal restrictions for parents, guardians, and so on. So being able to have some of that level of confidentiality was really important, and something that we discussed a lot about. But there are also confidential modifiers for billing purposes, ways in which the providers within their electronic health systems are able to flag things that are certainly sensitive, that you don't want, having that information end up in hands that the patient doesn't want to. So whether you're talking about an adolescent and maybe they need some contraceptive care. They don't want their parents finding out. If it gets billed, to their insurance, then that information is going to get back to the parent or guardian to which they are the insurance primary holder. Also, talking about considerations for youth and behavioral health patients. So really understanding what are some key sensitive areas. And also, I think important to think about role-based permissions for other staff members. So obviously, it's really important to kind of think about who needs to know this information, who is working directly hands-on with these folks. And it would be really important information for them to know, but maybe there are other staff members that it's not in their role or their purview to be able to have access to that. I think our presenters were at varying levels with this, and a lot of folks are still trying to figure out what does sort of those role-based permissions look like. What are some things that are super sensitive that just a handful of folks should have access to. So I think the conversation has started, and I think it's going to continue to evolve as folks are collecting more and more of this information. And it was just, I think, a really great conversation and something that's really important to highlight and to consider. Data use case and action. So what are health providers, if they were to be asked, this was our deep dive number 3, and looking at these use cases, we started out this convening just asking a general question to our participants, our presenters. What is the perfect situation for using this healthcare information? So if you could, in a perfect world, have a perfect system, a perfect process, what would that look like? And so some of the key areas that folks talked about when asked that question were being able to address access to care and health equity issues to the most vulnerable and underserved populations, being able to dissolve stigma associated with these social risk needs, being able to partner more closely with community-based organizations to connect patients with necessary cross-sector supports and services without fear of availability issues. And I'm just going to stop there for a second. I think that is huge. It's a really big deal. I think it's really hard still at times for particularly providers who know this is important information to have. They know they're being asked by their organizations, by accreditation folks. You need to ask these questions of your patients, but it's really hard to delve deep into some of these questions, just not knowing what resources are available for them, and that's really hard, and something I want us all to think about, and that to me is some of what really needs to be highlighted and focused as we move forward, is really understanding what are some of the community needs assessments that need to occur, but being able to ultimately support the providers that's going to support the individuals, and making sure that, yes, if they indicate housing instability is really important to them, it's really impacting their health, knowing that there are resources out there for folks to be able to get housing, to get food, to get heat, electricity, and so on. Also being able to meet folks where they're at by focusing on health literacy education and healthcare engagement, understanding too, like we talked about, education, training, being able to talk to folks about why this is important, really, include them in part of this process, help them, support them in autonomy and being able to make their own healthcare decisions, but doing it from that whole person lens and not just solely focusing on medical issues, that there's so much more beyond that. Reducing the amount of times that patients are asked to tell their story. So as I said, that was really a common theme to help individuals get what they need, but to not go through any unnecessary trauma or, any unnecessary, question asking or feel the need of why am I being asked again? I just told this person, this is really hard for me to talk about, or, just in general, you want people to feel like, they know what's going on and that you don't have to keep repeating yourself multiple times. But these were some really great examples of sort of that perfect situation question that we asked folks. How do healthcare providers use social health data elements at point of care? So trend assessment results, so screeners over time, as I mentioned, being able to incorporate that, being able to see how that changes for folks. Obviously, sometimes it can be more chronic in nature, sometimes it's more acute in nature, but really being able to incorporate what some of these responses are for individuals at varying times and varying points of their life. Being able to review the active problem list to inform decision-making, establish referrals that are incorporated into an intervention that help to mitigate that social risk and social need, and then engage caseworkers to help track outcomes in order to help folks reach their goals and to look at it from a goal perspective. Another great quote that came out of the convening, how are intervention recommendations communicated to the relevant care team members? Sometimes the greatest challenge is not the specific social risk identified. It is how you get the patient connected to the service that can help them. And that process is a social risk in and of itself. So as I mentioned in the previous slides, that seems to be where a lot of folks are at, is knowing that there are services out there that are going to help individuals. And to do it in a way, which I know I'm sort of jumping ahead, but doing it in a way that just knowing what's out there, knowing what's available. We live in a fast-paced world. Things change, services go away, new services, come in, and different folks that are doing that at the community level. So just being really in tuned to, what's available, but also to, like I said, what is the need? Having a way to show folks, whether it's at the state level, this is what a need is in our state, in a particular community in our state, and having that data to really back up some of those decisions. How are intervention recommendations communicated to different members of the care team? So whether it's a referral specialist, they receive the intervention request from a provider, gets triaged to a caseworker. That caseworker pairs the intervention with the diagnosis and other important patient care data to access a possible referral pathway. And you think about what that looks like as far as making that referral to the most appropriate organization and or service. So that caseworker connects the individual with whether, like I said, sometimes for our presenters, there were some services that folks were able to provide right within their organization, but then there are some times where it's an external referral and there's a need to go out into the community to be able to do that. And then having some follow-up in place. So, one thing too that we'll talk about and that I think folks have heard a lot of is sort of that closed loop referral process. But just being able to have some follow-up in place, being able to check in on that individual, making sure that they're getting what they need or that they were able to initiate a service, but just having those routine sort of check-ins to help, close out the process in general. How are healthcare providers finding available resources? So this is just a really neat graphic, I think, in looking at some of what we know is available for folks, whether they're using Find Help. So whether that for our health systems, if that's a part of your EHR, being able to use open beds through Maine Care 211. I think a lot of folks that we heard from had their own internal resource directories. So I think too, jumping ahead of myself, as we think about next steps, finding a way that if folks are, having their own, trackers or spreadsheets or things that they know in their area of different resources, who the contact is, what's needed to make those referrals, being able to share that information amongst everybody to really save, time in order to get folks what they need in a more efficient way is definitely something, that we'll talk about here in the final slides. But also transportation services, our areas on aging here in Maine, food banks, food baskets and things that folks are able to provide, but certainly this is just a brief look at some various resources that are available to folks. Use case and action. So what kinds of reporting are healthcare providers using for social health data? Patient level risk modeling. So using the information that they're getting as far as social health data and incorporating that within their medical data, population level risk modeling and resource availability assessments, and then grant funding and other opportunities and or requirements, whether it's what's asked of our presenters through HRSA and UDS reporting and so on. All right, so we're moving now into the information and discussion that we had around SOGI data. So how healthcare providers are collecting, storing, and using sexual orientation and gender identity information within their clinical workflows. These are some of the elements. I'm not going to go into each individual one here, but it's really just providing you with sort of these 6 foundational data elements that some of our folks are gathering and storing. Like I said, I think one of the biggest things was that everybody's at a different place with different components of these data elements that they're collecting in their systems right now, but these were really the main highlights. How is SOGI information collected by healthcare providers? This was the Maine Health use case. They did a presentation for us, which I highly recommend folks go back once we release the recordings that Brandy Brown did from the Gender Clinic at Maine Medical Partners through Maine Health. Just really great information. And there was also another presentation done by her team during the 3rd convening around use case. But ultimately what they were able to talk about was that they partnered with Fenway Health to determine sort of data collection approaches. They've been able to operationalize how to gather this information. It initially started with ambulatory providers, moved to inpatient, with the hope that it reaches the entire Maine Health organization by 2024. There's no standardized way in which the data is collected, but different departments collect different data elements based upon need and use case. There is targeted training for the gender clinic, for the emergency department, the psychiatric department, OBGYN clinics settings. No specific scripting, but what they really talked about was that a lot of times it's just helpful to, talk through some different scenarios for individuals when they are asking this information, and they may get questions back from individuals that they're just able to get that training and that support for staff that are being asked to gather this information. As with some of the other areas that we talked about with social health, is that this is primarily collected during pre-registration or on-site registration by clinical and admin staff. Best if staff collecting the information have an established relationship with this patient. I think that's always, really helpful that somebody who's been working with this individual really closely or on an ongoing basis, is able to get this information from individuals, and even better if they can fill it out independently before their visit. So like I said, being able to answer the questions at whatever comfort level they want to, whether it's at their home or wherever they are outside of that, office setting, that it's them providing the information. Current data collection challenges include, it's not always clear which staff role or department should collect the information, and that it's not a mandatory clinical practice, but really, what they drove home in their presentation was that it's really most successful when patients are able to enter it on their own. What we talked about as a convening is that, and with our presenters, is that the information is primarily collected during registration, either via paper forms or a conversation that happens with providers. Increasingly, it's being included in that pre-registration patient portals or that self-service kiosk that we mentioned before. Additionally, adding questions to patient satisfaction or experience surveys are helping to determine how organizations are doing as far as these data collection efforts. Northern Light spoke about their upcoming Why We Ask communication campaign, which I thought was really, excellent and spot on, is to have an understanding of, why, once again, why is this being asked? Why is it important? And just being able to provide more education to individuals, once they're receiving healthcare. Why are folks asking them of this? Current data collection challenges include lack of clinical, training when it comes to conversations, lack of a registration process or workflow that is really optimal to getting the information, and then lack of recognition of a standardized approach. So looking at the purpose for collecting the information beyond healthcare organizations. So looking at payers, funders, referring organizations, and so on. What Maine Health highlighted is that they use an Epic Smart form to enter in some preferred pronouns and non-discrete data elements in a free text box. The information is stored in a separate tab. Preferred pronouns are always displayed within clinical records for easy viewing. And though any changes made in the information are audited and reviewed by providers at point of care. So when the information does get into the record, it is always reviewed similar to the social health data. The Epic Smart form is not protected or confidential. The information is available to anyone in registration or who has clinical permissions to do so. And that the information is also stored in MyChart, which is the patient portal that Maine Health has. How are other folks storing this data? Really varied. Some are stored discreetly, some are stored in forms, some are made more visible in patient charts. So in looking at sex assigned at birth and preferred pronouns, others are displaying legal sex, gender identity. The information is not protected or confidential. It's available to anyone too that had registration or clinical permissions within the organization. There may be some blocked information if it's information that is being collected in a behavioral health setting, but that seemed to be sort of the only restriction or any need for having a privacy seal break. So one of the also big things, and like I said, I would certainly encourage folks to go back and listen to some of our recordings, but another great use case that the folks at Maine Health shared about that I just want to highlight is really the rooming and how there are rooming patients at their organization. They adopted a new system-wide policy in 2022 that prioritizes patients' rooms based upon their gender identity, that if that's available, and then legal sex if gender identity is unavailable. So some really great things that they are doing, and I think really educated us and some of the other presenters on what they're doing. And hopefully that's something that other folks can seek more information about, more training about, and hopefully can adopt at their own organizations. But that ultimately, training, like I said, I'm a broken record. Training and education is really important. Being able to give providers more confidence in their treatment plans and decision-making when working with individuals. And then obviously that will help create that dialogue, establish that trusting relationship, and being able to make necessary referrals as needed, whether it's to the gender clinic or other community-based LGBTQIA+ supports and services in the communities. Whoops. Some use cases, obviously, training and education. There are federal reporting requirements in which this information is used in other funding applications, point of care treatment plans, and decision-making capabilities, necessary referrals that I just mentioned, as well as any new gender affirming program development for folks as they are looking forward. All right, so how can HealthInfoNet support healthcare providers with ongoing data collection, storage, and use case efforts? So as we're wrapping up this webinar, there are some things that we want to highlight and talk about. So how can we at HealthInfoNet establish greater relationships and assist, our participants? Really what we see for ourselves as being a conduit and a way to bring folks together. So even though we're not providing, the individualized patient care and we're not providing the specific education, it's really important for us to be able to use the data that's being shared within the exchange and giving folks an opportunity to have access to that. So expanding our participation, looking at identifying the CBOs, and making sure, are they able to meet the participant requirements and getting them onboarded to the exchange through CAP agencies and AAAs, receive CBO client service data and healthcare provider social risk information. So taking in that for our current participants, as well as receiving that SOGI information and having that be shared in the statewide longitudinal health record. Being able to enhance the partnerships that we have, so having a tighter integration with cross-sector technology systems, whether that's Find Help or other folks, helping to build that resource directory. So as I mentioned, a lot of folks have internal ways of doing that. And so how can we bring all of that information together and make that shareable amongst all of the folks in the state, and which will ultimately help as they are making referrals and following up on interventions. Partnering with subject matter experts to help train and educate our participants on social health needs and SOGI use cases. So as I said, we really want to be that conduit to help bring folks together. We have a lot of these relationships. And so it's really important for us, as we've done with this convening, to just bring folks to the table and give them a way to talk to each other and ask questions and learn from each other. It's very important for our participants and our mission to do this for the individuals of the state of Maine. And then also being able to support the CIE efforts. So serving as a partner in the statewide community information exchange project to enhance that interoperability to improve whole person care. This is just a highlight of some of our services and tools, whether it's our clinical portal, whether it's our notifications or our analytics and reporting platform that we have. Being able to incorporate aspects of social health and SOGI into all three of these areas is something that's really important to us, and something that you will see us working on in the future. And then what are next steps? So what is to come with this social health data action plan? So to wrap things up here, what we are working to do, as I said, we really just want to be a partner in this work, help make these connections, help bring people together. It's really important to keep this conversation going and to have folks be able to share with each other, whether it's what are the lessons learned, what have they done, what is working really well, what are some of the things that they're thinking about, in the future, being able to encourage sort of these network opportunities, whether it's how they collect the data, how they share the data. If some folks are aware of, whether it's a grant project or a funding opportunity, being able to work together and not necessarily feel like folks are working in silos, that we can sort of help bridge, that gap. And here at HealthInfoNet in particular, we're very open to working with folks and seeing how we can help or what we can share and what we can do to bring folks together to make sure that this work moves forward. Like I said, all of the convening sessions were recorded. We have slides and materials that will be shared with our attendees. We're also going to be sharing a survey that's going to be sent to all HIE participants about social health and SOGI data collection, storage, and use cases, and to get their experiences and to get their feedback. There's going to be social health data action plan recommendations considered within our upcoming strategic planning conversations. And then progress on short-term and long-term recommendations will be reported through key communication methods. So we will definitely keep folks updated. But like I said, too, we're going to be sharing a lot of things out to folks, but we are, we want to hear folks' thoughts. We want to hear their feelings, their suggestions, their ideas, and how we can help too. And bring folks together. Certainly, as folks continue to have these discussions within their own organization, you can always feel free to reach out to us at our clinicaleducation@HealthInfoNet.org email. That's a great contact for folks. And here is our generalized information here at HealthInfoNet. I know we're at the 1 o'clock hour. I just want to say thank you, thank you, thank you. We appreciate all of you taking the time to listen to this, to review the information. We had some really awesome, great, wonderful conversations. We are so thankful to our presenters, and we're really just excited to continue this conversation and improve the quality of life for folks here in Maine. So thank you again, and I hope you have a wonderful rest of your day.